Good morning, everybody. We shall start now. Thank you very much for coming in time in this very early morning on a Sunday morning. Without further ado, we shall start. This session is about APLC working group updates. As you know, yesterday afternoon we have gathered in several working groups and come up with certain ideas. So I think this is a time where we're going to share with everybody what our working group updates are. So I have with me, I'm Jinjin. I'm from University Malaya. I'm a consultant hematologist. And with me is Professor Wang Yin. Yeah. All right. Who is from China. Okay. So I shall first start with the updates from our acute myeloid working group, who will be presented by Professor Hao Xing An. Thank you very much, Professor.
Good morning, everyone. On behalf of APLC AML Working Group, I would like to give you some plans and update of this working group. It will divide into three aspects. The first one is Asian Pacific AML guideline or consensus. The second is the Free ITD MRD platform. And the third one is survey of secondary AML. I think we are all aware AML is a very heterogeneous disease where several treatment guidelines or consensus and a lot of information from different important meetings such as ASCO, ASH, SOHO, EHA. Regarding the AML Pacific AML guideline or consensus, I think we think it's very important because it's an essential tool in harmonized AML care, improve outcome, and addressing the specific needs and challenges of the Asia Pacific region. It will divide into several important points. The first one is the regional variation in patient demographics compared to a Western country. Second is a difference in access to resource. And we are aware that resource availability varies widely across Asian Pacific countries. And it will impact the diagnosis, therapeutic option, and supportive care. The third one is prevalence of distinct AML subtypes. I think a lot of information and data suggests that certain AML subtypes, for example, CBPF double mutation is more prevalent in Asia Pacific area. And those related to specific gene mutation or environment exposure may be more common in this area. And the first one is availability in healthcare infrastructure. I think in this area, we have different countries with the different healthcare system. So a regional guideline can help ensure the more standardized, equitable care across diverse healthcare environments. And the next one is, I think the AML guideline or consensus will encourage regional collaboration in research. And it is also very important to adaptation to regional challenges. Treatment adherence, access to novel therapy and follow-up care can be challenging in some Asia Pacific area. So a regional guideline could provide practical solution and a pathway toward to this logistic and socio-economic constraint. And it's very important to address unique treatment-related toxicity. And also less important to have a consistency in clinical practice and training. At this moment, the Asia Pacific AML guideline and consensus is in progress. We are correcting the guideline of all standard of practice according to participating centers. I think this is the first project. I think we are aware it's very important to personalize the AML care, such as risk location and diagnosis. Another important issue is in 2021, EOL proposed MRD update in AML care. And we have several methodologies to detect MRD, including flow cytometry, quantification, PCR, NGS, or digital PCR. And for example, in Taiwan, we have a Taiwan AML guideline, and it shows the time points how to monitor MRD. However, I think the time points is quite diverse in different countries, especially in this area. According to 2021 year MRD monitoring regarding NPM1 co-multifactor leukemia, I see the data is very strong. So we know how to monitor and how to interpret the value of MRD in clinical care. And another important tool is flow cytometry for AML. I think another very important MRD monitoring is the free-stream ITD. Yeah, because free-stream ITD predict for prognosis. According to Professor Levis' talk yesterday, we know PCR NGS could provide a very sensitivity regarding to 10-6. And it will help to detect, especially after target therapy, the deeper treatment response is very important. The original study suggests using the fluorescence-based PCR technique, if the patient can achieve the deeper response, the outcome will be better and will have a lower post-transplant relapse risk. Recently, the Andrew Weiss group suggests using PCR NGS, you can detect 10-6. I see from this slide you can find if a patient have any kinds of free ITT transfer, the treatment outcome was very poor, has a very high probability of relapse and shorter overall survival. And another important issue is MAC transplantation could not eliminate the poor outcome of a free ITT pre-transplant. So I think that's important. We have a free ITT MRT platform in this area. It is instrumental in enhancing free ITT ML care, supporting precision medicine, and ultimately improve patient outcome in this area. And there are several important issues. High prevalence of free mutation in the world and also in this area. And I think we have regional variability in treatment response, possibly due to the genetic diversity. Another very important issue is how to standardize the MRD assessment in this area, because at this moment we do not have a MRD a standardized ratio of MRD assessment, leading to variability in treatment outcome. And how to assess the target therapy monitoring is also an important issue. Finally, how to early detection of this disease is very important. It will change the treatment policy, and it will result in advanced precision medicine in AML. Of course, we hope this platform can facilitate regional research and data collection, and it will build local expertise and training for younger generation doctors. And finally, we hope this data could help in support health policy and reimbursement. I think this is a very important issue in Asia Pacific countries. This project will be led by Dr. Han from Singapore. And at this moment, the free CIT testing in Asia Pacific area is not adequate. All Pacific centers except for Australia do not have a high sensitivity plan for PCR NGS. I think the main issue is regarding the patient number needing the test and the turnaround time. China, Singapore, South Korea, and Taiwan currently are developing the high sensitivity test. The final project is to survey of secondary AML. Secondary AML defined as AML with no prior hematology disease. And we exclude AML with a disease-defined mutation of fission. MDS or MPN or other hematologic disease transfer AML will be included. Due to TP53 AML has a poor outcome, so we exclude this subpopulation. And at this moment, the most hematologists suggest allogeneic stem cell transplantation for eligible patients, and intensive induction chemotherapy or low intensity regimen such as venetoclax-based regimen could be used as a pre-transplant therapy. And some countries are more tiered toward using of the RCTD or DCIB in combination with venetoclax. For such patients, regarding of age, as intensive chemotherapy appear to more toxic and less efficient as a bridge therapy into complete remission. CPS 351, the standard care in secondary AML, is not widely available in this area. And we try to conduct a survey of the standards and of management for secondary AML across the participant institute. And this part will be toward doing a retrospective study of a patient with a particular center. I think the wish and the goal of APLC AML working group is try to do personalized and personalized care in AML. And thank you very much for your attention. And this is my sharing and the working group wish everyone's comments and feedback. Thank you.
Thank you very much, Professor. Perhaps you want to sit here? Yeah, so that I think we have 5 minutes for discussion on the project. Yes. So yeah. So I see that there's 3 projects. So does anyone have any question or clarification, especially for Professor Ho? I have one. If I may, you have your second project that is going to be leading by Tan Hin from Singapore. It's a MRD. I think it's a fantastic project. I'm just wondering, uh, is it only involving Singapore, South Korea, Taiwan, and South? Because I'm not sure whether other participating centers would have that availability of MRD. And are you looking at MRD by flow or NGS? Just wondering.
I think in the after meeting yesterday, we talked about this issue and we suggest each country maybe have a center who be a pioneer to do this work. Where this PCR NGS platform has very high sensitivity. I think it's very important in clinical practice. Of course, Tantan will share the universal platform and possibly we have a TC conference before to start this project.
Sorry, I'm just wondering because I know of a certain country may not have that availability. Would there be a resources where, I don't know, would you be looking at some kind of a system from pharmaceutical or industry or university itself, or whether is there a possibility of the centers that do not have that resources to be able to send to Singapore, for example? As an example, I'm just wondering.
Thanks for the question. So, I mean, on behalf of our working group, so I think what we discussed yesterday was that, I mean, our lab in Singapore will probably start trying to develop the PCR NGS assay, very similar to what has been done in Australia at this point in time. So then we will have a regular work group meeting, like each country representative from the region, from this APLC group, will meet up regularly to kind of follow up on the progress. So the intention is that once we have developed it, validated it, then of course wanted to kind of invite all the participating countries to see whether we can develop it in each center or maybe there's a reference center initially where all the samples can be sent, and it's like a platform to set up the further kind of standardization in the region. I think that's kind of the long-term plan, but I guess in the short-term plan is for us to develop it and see whether it's kind of technically feasible and also financially sustainable.
Thank you very much. I think Prof. Go has a comment.
So maybe some comments and advice. So I guess last year also we had the same from various groups, and there's like we probably need some continuity and follow through. So like each of the projects, I think it's good to go on, and then next year we update, right? So like for Tan Hin's one, you can update that what has been done and so forth. And for funding, you also need to fund your own projects. APLC has got no money to fund you. So for example, the CLL and for ALL, we managed to get a sponsor from China thanks to the co-chair. And then they actually fund the medical writing for the AL project. And then medical writing is much easier with a medical writer. So we can actually do that for you. You tell us who the sponsors are, we can write on your behalf, and then we can solicit. And even for the MRD project, if you want to, let's say, get a company like Stellas or something, also we can also reach out, or you all can reach out yourself. So whichever is easier. And then even like your secondary AML project can also consider even the MRD, you also can collect data. So maybe it also can link up with the registry group. Actually, as he sort of speaks, then actually not only just we can collect the data, but we also have something to publish. So I think I've mentioned yesterday, publishing is very important, so that at least we can have presence and people will then come to us more. So it's important to not only just have the data but publish. Okay, so work with APLC. Okay.
Is there any other question or comment from the floor? All right, thank you very much, Professor Ho, on behalf of the AML working group. I think looks like it's very good project, and I think yeah, hopeful to hear more updates next year. Okay, thank you very much, Professor Ho. All right, I pass it to my co-chair.
Yeah. So next we move to the ALL. Thank you. Working group. So let's introduce the speaker, Carl Chen, professor from Queen Mary Hospital, Hong Kong.
Good morning, colleagues. I'm Carol from Hong Kong. Today I'm happy to present some updates and plans on behalf of the AL Working Group. So just a bit of recap of what we discussed last year, 1 year ago. We would like to establish some sort of communication channel with making use of some IM platform for our working group members, which we set up. And Dr. Ashley of Australia also regularly updated us all sorts of new journals, conferences, etc. So there's a means for us to communicate and also to update the members about the progress of our project. And we also discussed about the possibility of drafting and writing some consensus guidelines. And so I'm glad to update that we have currently 2 consensus guidelines underway. So we, just as what Prof. Goff just mentioned, we are very fortunate to have support from our mainland counterpart with both Professor Wang's help. And so we are now in the final stage of negotiation with our sponsor. And so we have a hopefully who can support us with some medical writing service. And in our group, we have a very good representation from various regions of the APAC. And though I have to do a bit of advertisement here, is we are still lacking someone from Japan. So if you happen to know any any person with interest in ALL who would be interested in joining this consensus guideline project, please do let us know. So our 2 projects would be the first one would be on MRD, that's the assessment and management of MRD in adult ALL patients. And the second one would be about asparaginase, both a native and the pegylated form. So at the breakout session yesterday, we are very fortunate to have Prof. Mark Lisso together with us as well. And so we have quite a bit of interesting discussion around various topics. So for example, the first one, which is also related to our upcoming consensus guideline project, is the use of R-asparaginase or the pegylated form. For your information, last year, in fact, many member countries expressed that there is a very they're worried that they may not be able to secure adequate stock of the native asparaginase in their home country. And then many of them expressed that they anticipated they may be so-called like forced to switch to the pegylated form. And that's why it is also why we came up with the project, because many members were worried about the switching, about the toxicity, about the dose conversion, etc. So apparently over the past year, the supply seems to be more stabilized and with the native form. So we, in the breakout session yesterday, we shared the latest situation in different regions and the availability of different formulations. And we also discussed the availability of the serum asparaginase activity test, when we measure that, and whether there's any possibility of finding any surrogate markers to indicate the level. And we also covered how we usually manage some asparaginase associated toxicity, infection, or some members share some really serious case of hepatotoxicity relating to the asparaginase use. And we also discussed whether it's possible to identify some dose reduction strategy, which apparently is not really well reported or in the literature now. And the secondly, of course, as I said, we are very fortunate to have Prof. Lisso in the group as well. So we take this, and obviously the publication of the E1910 trial data recently in the New England Journal has really been a game-changing practice. So we have quite an extensive discussion on the use of blinatumomab, including the approved indications in various countries or regions of the APEC, how it is funded. But though mostly it still appears to be privately funded, though some in certain countries it may be reimbursed for certain indications like relapsed refractory setting or the MRD setting. We discussed how monoclonal antibody, including blinatumomab and inotuzumab, could be incorporated into frontline treatment of ALL, what ALL patient groups, and the time point, whether it's after first cycle, like induction, or 1A, 1B, depending on which protocol regimens you're using. And we have the chance to ask the first-hand experience from Prof. and about some trial data like the efficacy, how many cycles, the toxicities, especially like CRS, ICANS, and etc. And whether he encountered any like relapse during or MRD relapse during the blinatumomab therapy. And in the audience, we are also glad to have some industrial partners from Amgen, so who can also update us about the possibility of a subcutaneous formulations in the not so near future. And we have Prof. Wang here, so we also, and of course, I believe all of you know that mainland China has very extensive experience in the CAR-T product, and especially and also which sometimes they also follow it with a allotransplant. So they share their CAR-T experience with us. How they because in mainland China, blinatumomab is not reimbursable. So instead of blinatumomab, actually they would rather invite patients to join the CAR-T trial as a form of consolidation. We also briefly touch on, which is another very hit topic in the field of ALL, that is chemo-free treatment in the form of a TKI plus blinatumomab for the treatment of Ph-positive ALL patients. Lastly, we also, apart from our two consensus guideline projects, which are already in progress, we also try to explore whether there are any other opportunities for collaboration of different members as a group. So we also are thinking that maybe for some really rare, of course, obviously AL is not a very common hematological condition, but we are talking about even more rare conditions in adult patients, for example, lymphoblastic lymphoma. So maybe in each region or each country or in each of our own hospital, maybe there will be only a handful of, say, LBL cases. So we are thinking maybe we can have gather these cases together, have a bigger case series or retrospective review so that this is what we can do as a group. So for our priorities and in the coming year, obviously we would like to maintain and enhance communication channel through various electronic means mainly. And we also discuss how we divide the neighbor or with all these projects among ourselves. And the two focus with that, hopefully in the coming year, we can complete the two consensus guideline projects on MRD and the asparaginase respectively. And we will also further explore on the other ideas and including how the availability and use of blinatumomab in the APAC region, as well as say the LBL, just as what I discussed. So this is my last slide. So this is the plan that we come up. So the first one, maintain and enhance communication channel would be I myself and Ashley. And so basically I'm the middleman between, because I think one interesting part with the APAC is that different countries or cities have their own electronic means. Say many of us are using WhatsApp, and some regions is using WeChat, and I found Taiwan colleagues now using Line. So in fact, they are very different social media platforms. So I'm kind of the middleman now. I have many all these apps in my phone so that I can forward the message apart from email. Okay, and so hopefully, and obviously, if we are going to say like some more like big conference, ASH, EHA, or some other bigger. Hopefully we can, if we are going to attend that physically, we can still have a like smaller group gather around. And the consensus guideline project will be led by myself and also Jinjin, yes, from Malaysia. And the project on the asparaginase, we're trying to involve those who are still using the native formulation as well as those who have switched to the pegylated formulation already. So we have Ida from Singapore, and also we have some Thai colleagues, Adisak and also Wasihab, to help Ida to really lead the project. Obviously, the rest of the groups will also contribute in the consensus, but in the coordinating will be we are glad that they kindly agreed to help us with all those coordinating work. And as for other ideas, as I mentioned, we are very happy to have the Amgen partners in the meeting. So they already kindly agreed to support, in principle, our project on blinatumomab. So hopefully we can, because I think the members in our group also all agree that with the expanded indication of blinatumomab from at the very beginning only in the relapsed refractory setting to now to then the MRD positive cases few years ago, and now as a even consolidation for everybody, literally. So it is foreseeable that the use of blinatumomab will be wider and wider and much more. So I think it would be important for us to gather all this information, how it affect our practice, so that the member countries our members can also hopefully use these publication to really persuade or the local government or local authorities to help with the allowing the access of the drugs to the needy patients. So we have Dr. Ye of Taiwan, and we also have Ashley and Jichuan of Singapore to help with that. And LBL, we are in the exploratory stage, and we have Melissa to help and to see together the cases. So this is all what I want to present. And
thank you, Professor Chen. And would you have a place on the table? Any questions for ALL working group? So I just discussed yesterday. We talk about some collaboration in real condition like LBL. Maybe I think TLL we missed. So maybe we can collaboration in TL.
Right. That's true. Yes.
Have no question. Maybe we. Thank you.
I'm
Professor
glad that
Chen
this year Paul got no question.
Very detailed, so no problem.
Thank you.
Thank you. Thank you. Let's move to the next speaker, CLL Working Group, Professor Lalita from Chiang Mai University Hospital.
Good morning, everyone, and thank you so much. So I would like to summarize what we have discussed during the breakouts for CLL's working groups. We touch bases in two major issues. First, in registries, and second, in consensus in management of CLL in our regions. In terms of registry, Professor Mulligan shows us how successful they can conduct the prospective observational studies in Australia. And currently is there around over 800 CLL patients, and they're using the platform, the Red Cap platform. And some of the countries already got their own registry, mainly hospital-based. In Thailand, we got nationwide registry. However, it's not like comprehensive all the information kind like toward clinical data. So registry for CLL is possible to conduct across APEC countries. However, we're leaving the decision whether we're going to do that or not, including the funding to the registry team. For the second half of our talk, we discussed about we may get the consensus guideline in management of patients with CLL in our regions, and we have a chance to invite. We have invited two delegates from each countries, and we got some name on that. And some country we have to wait for other persons. And now we can. So with these issues, like more than right now, we got more than over half of delegates. So then we proceed to do some consensus that we can do yesterday. And I would like to touch bases in some points that we discussed yesterday. We mainly focus in 6 issues. First, in terms of treatments. Second, personalized patients management of CLL. Third, treatment monitoring. Fourth, outcome and prognosis. And including comorbidities, long-term care, and patients' communications. So first, for treatment approach, the question is there any key factors for decisions between watch and wait, watchful waiting or active treatment for a symptomatic case? However, currently there's no any evidence of benefit of treating patients in asymptomatic stage. We would not recommend to give the patients any kind of treatment at this point. In terms of genetic marker, of course, the most important ones is a FITCH for 17p deletions and TP53 mutations. The other, including conventional karyotype and IGHV status, is still option. In terms of treating autoimmune cytopenia, if the patient's got only autoimmune cytopenia secondary to CLL, treat autoimmune first, mainly corticosteroids. However, if they not respond well, CLL treatment is indicated. So for any roles of chemoimmunotherapy, of course, for patients who have a mutated IGHV in younger patients and fit, we would there's still a role for chemoimmunotherapy. In terms of our for patients with significant cardiac disease, who's not eligible for ibrutinib treatments or who's ongoing treatment with vitamin K antagonist, what should we do? For patients with stable cardiac conditions, other BTKs inhibitors and options, and if they need anticoagulants, DOACs, especially episabans, can be an option, or otherwise for patient who have concern of their cardiac issue, switch class to BCL2 inhibitors plus anti-CD20 monoclonal antibodies. In terms of how to choose between BTK, so depending on the access, if all three are accessible, we second generation because of the safety issue, and some has more efficacy, have a higher efficacy. So then second generation BTKIs is preferable than the first generations. For patients who develop BTKI resistance, Professor Mulligan's and the consensus have the same would like to focus that if they continuous ongoing treatment with BTKIs, but with increasing lymphocytosis, that before going to other treatments, the ongoing one should not stop immediately. We need to find some other way to treat the patient, should not just stop BTKIs. Otherwise, the patient would get or lactic acidosis or get worse because of abrupt stopping BTKIs. So the options to, if they have resistance to ongoing BTKI, the option is to switch to the other BTKIs. If there's if BTK gene mutation is accessible, but in our working group, only Australia is accessible for look up for BTK gene mutations. If they don't have resistant genes to BTKI, the patients can switch to the other BTKIs. For otherwise, we recommend to switch to non-covalent BTKIs, and also in case that gene mutation can be done, the patient should not have T474I mutations in that case before switching to non-covalent BTKIs. Otherwise, switch class to BCL2 inhibitors, or if they are fit enough, chemoimmunotherapy is an option. For any role for allogeneic transplant, especially there's still a role of allo transplant for double refractory CLL if there's available donor. And for in terms of personalized patients management, of course, for patients with in terms of risk factors, comorbidity, we still think CIRS is a good tool to define fitness comorbidity of these patients. However, genetic assessment, we think that for older patients, if they have comorbidity, CIRS would be a good tool, and they would help to imply the fitness of elderly patients as well. And for patients who resist to target treatments, the same. So if they are on BTKI, switching class to BCL2, or if they are on they resist to BCL2 inhibitors, switching to BTKIs. However, for double refractory, allotransplant is an option. However, if there is available clinical trials on CAR T cells, the patients should be enrolled in that, can be enrolled in that clinical trials. For treatment monitoring, the response criteria, we would refer to the International Working Group of CLL response criteria. For MRD, MRD is still not a part of our routine clinical practice. For patients who have to monitor for adverse events, AFib, and also bleeding, we just need our clinical monitorings. And of course, for patients with for tumor lysis syndrome, especially for starting the new treatment, laboratory monitoring for tumor lysis is needed. And for outcome and prognosis, genetic status, TP53, it's still helpful for long-term prognosis. in terms of management of comorbidities, we would recommend to monitor for patients that may have developed cardiac conditions, especially those who are on long-term BTKIs, and also monitor for long-term second primary malignancies. And we emphasize on immunizations and infectious prophylaxis for these patients. And for patients' educations, we have made a strong consensus that clinicians should communicate with the patients about the nature of CLL that tend to be chronic and potential to relapse and need a long-term management. So after we complete all these consensus, manuscripts can be written by the medical writers, and then after finish drafting manuscript, all the panelists will be reviewed, revised, and we hope we would get the publications. And I think this is all our consensus for CLL working group.
Thank you. Thank you, Professor Lolita. Please sit on the table. And any question for CLL working group? Yeah, for CLL patients, we do need long-term management, and I want to know in the different country or regions have a different healthcare system, how to do the same long-term management.
Oh, that's a very difficult questions. In terms of monitoring patients for adverse events, for bleeding and AFib, I think we are the same. Mainly is clinical. I don't think we recommend to do like monitor any kind of EKG or anything. So we just observe patients when encounter the clinic. This is what I think we have to do and assess any yeah, for in terms of efficacy of treatment, we just follow the general international working criteria. I think we practice almost the same. I don't think we have any specials. Especially we already made consensus about MRD may not be an option in clinical practice.
Can I just ask a question? Your consensus guideline, some of it require quite high-tech resources. So I'm assuming your consensus guideline will be tailored to certain resource, resource limited, resource enhanced. How would your consensus guideline be drafted? Because it's quite important that all participating countries are able to have an idea or make use of this consensus guideline. And if they do not have the resources, how do we approach it? So is that a plan for your consensus guideline?
I don't think we have a plan that we would go for if there's any limited resources, because we can give like a general guidelines. I don't think we would, put that differently in terms of resource. Yes, Professor Supang.
Just would like to make some comment that in some of our countries, and especially even in Thailand, we do have some patients who cannot afford BTKI or the standard international. My question is that should we include the chemoimmunotherapy like rituximab, bendamustine for unfit patients or elderly patients who we do not aim at target therapy?
Yeah.
So to answer both questions, so for the resource stratified countries, this approach has a lot of people have been asking now, and I think we have the initial publication that we did, and in that we sort of address some of the resource stratified, what you do, what is important, and what is good to have, what is not good to have. So for as far as the diagnostic, we are not going to repeat that. We'll just reference the previous one. For this one, it's very difficult because it's a very rapidly moving field. So and then some may not have let's say Zenu or second gen and this and that and so forth. So it's difficult to encompass the whole lot. We will see what is our ideal and then what is our alternative, and then that will probably cover everything. And also to Supon's question, also I think we also discussed like a lot of countries still use apart from FCR for the very, very good risk group, for chemoimmunotherapy, for the also fairly good risk group, either the good risk or the very good intermediate risk group. And in the older patients, bendamustine rituximab is still feasible, so we also will include that. In fact, for our Singapore guidelines, some people do quite strongly put that, and even chlorambucil, obin, or something like that. So all this will be included for that, so that it includes the right ranging practices in the region.
Thank you very much. Yes, Dr. Lim Sumin has a question or comment.
Any discussion on the TP53 gene mutation, 10 to 10% that will be missed by the fish? In Malaysia, we don't have a single gene TP53 mutation. Just wonder what's the situation in the country so that we don't treat this patient with.
Right, we don't discuss about, I mean, in terms of availabilities of the TP53 in the working group at all, because we we don't touch base in the method as well, and most of the country that in the consensus in the working group can access to TP53 mutations. So then, yeah, but Malaysia, so
Maybe I help you up. So yes, so fish is quite good, but if you do fish alone, there will be some fish negative and TP53 aggregated patients. You miss about 20 to 30% depending on your population. So in that group, and if you don't have and you suspect, then of course the safer way is just to use the BTKI continuous. Unless you are in that group where you will opt for a fixed duration therapy in the P53, which is quite rare. So if you don't have and you want to be very sure, then you just use the BTKI continuous. That will be the safest lah. I hope that answers your question. But if it's going to be P53 positive and abrogated, and you can't do, and if you are still going to offer fixed duration because the data is not so good, but if you believe the patient is older and you can still get quite good long way with it, then you can also offer that. But you will be missing out 20 to 30%. If of course in a very young patient and so forth, and when you are going for a very longer term SCR and you can't do P53, then we would not recommend doing FCR. All this will be hopefully in our guidelines once we write. It's getting more and more complicated because everybody wants this and that, right? So it's not easy to do a guideline. Yeah, and thanks.
Any other comments? No? Oh, Dr. Jerome.
Hello. Yeah, I was just wondering, in the guidelines, would there be any sort of recommendation to manage the adverse events, especially with regards to bleeding adverse events? Because many of the patients sometimes are on single antiplatelet, double antiplatelet, they're on antiplatelet plus anticoagulation, and some of these patients may need to go for example, surgery, tooth extraction. So would you touch on some evidence and recommendation for managing?
for yesterday we mentioned about some bleeding, whether how to monitor and recommends on those who's on mainly anticoagulants, but we don't even touch bases on the patients who's on antiplatelets. It's a good point that should put that in a guideline as well.
Okay, thank you very much, Professor Lalita. I think we will move on to the next working group. The next working group is Registry Working Group. I think Dr. Ashley will present on behalf, and also Professor Ko Bo Sheng as well as Dr. Lau. Not Lau. Okay, just. No, also Dr. Lau Xiantang.
Good morning, and thank you very much. Just allowed to leave a bit early, but Professor Ko is here with me today. So we're going to talk about thinking about registry development in the Asia-Pacific region, and perhaps I'll talk a little bit about what we talked about last year. And the idea of the registries across multiple countries, they're just databases to systematically collect and collate health-related information for our patients on the disease, the conditions, and treatments. And really we want to try and improve patient care, facilitating research, as well as also informing healthcare policy. And this is a very vibrant area in hematology at the moment. There are a lot of changes and improvements in patient outcomes with the availability of diagnostic testing and also new therapeutics. So previous studies looking at leukemia, for example, in the Asia-Pacific region have used large worldwide global registry databases where the standardized collection of information from national bodies has been used and aggregated so the information can be collated in a way that can be understood and compared across countries. What we do want to do when we start to develop registries within the APAC region is look about that standardization, both of collection and analysis. What we have known from other registries that these have been very successful in terms of, for example, the CIB-MTR. When you need accreditation from that, that's why hospitals contribute patient-level data to those registries. As mentioned before in the CLL working group, the lymphoma myeloma-related disease registry run out of Monash University has collected information from CLL and myeloma and been very successful in terms of standardized collection of data, as well as reporting back to the sites about outcomes of their patients to different therapies. From the Australian Leukemia and Lymphoma Group, for which I'm a member, the National Blood Cancer Registry was established for patients primarily entering clinical trials in Australia and New Zealand, where that information is standardized and collected with trial outcomes. However, as we know, this takes a lot of scope, vision, and resources, and there is an ongoing cost required to maintain these standards. Our discussion from last year was to look at what the feasibility across different countries for contribution to a standardized registry. And it was actually not the technical issues about establishing a platform. It was much more about the governance issues about data sharing of patient-level information to a central repository, where different countries have different types of criteria and governance requirements, and also potential limitations to what could be shared outside their country. So the definitions of retrospective data studies as quality assurance and evaluation studies did vary across different jurisdictions, and there was a lot of complexity around multilateral agreements in terms of data transfer agreements. There's also within countries significant restrictions sometimes regarding patient-level data sharing. The variations in clinical data, how it may be collected and used, was also an issue. And these are the biggest issues beyond the technical issues for collecting a standardized, centralized registry, which is facing our region and facing the initiatives here. So what we have to come to grips with and what we can have to adapt to is thinking about site-specific flexibility for participation and contribution to any types of project-specific registries. So in terms of the roadmap or what we can think about in terms of moving this forward is thinking about a project-specific registry focus. And these projects we are thinking about, as mentioned in the AML working group, as well as the ALL working group, was a project-specific, which is not completely comprehensive in terms of capturing all patients treated, for example, for disease, but a focus on specific types of issues that have been brought up as priorities in each of the working groups. So from the AML working group, for instance, the issue we can focus not just on clinical, but also diagnostic registries for genomics. And as we know, genomics has become a big influence in terms of how we diagnose and manage disease in 2022 onwards. So, for example, from the AML registry, the idea of understanding and collecting information about how molecular testing is done for FLT3 mutations, for instance, of TP3 mutation, for instance. That's a much more acceptable way, for example, of sharing data as a quality assurance projects across molecular laboratories, but yet serving as a standard by which we can start to understand how diagnoses are being made across different countries, for example, FLT3 mutated AML, and how treatment is being monitored. So from each of these working groups, we're very interested in having site-specific investigators, potentially as in parallel, thinking about if people are wanting to contribute to small pilot projects or patient-level data, developing the governance structures and multi-site ethics, as well as the data transfer agreements. Importantly, however, we want to make sure that when we're starting to these pilot projects, by establishing a common data model about how we collect information as well as how we analyze the information, will allow a federated approach. That means for the PIs at sites, we actually don't need to transfer data to a central registry, but we can actually have the data collection and analysis performed in a standardized way, and the totality of the de-identified aggregate data being compared across different countries. That would allow some projects to move forward without having very detailed ethics and also multi-site agreements in place. So we have project support from REDCap, from my institution, Peter MacCallum or Walter Eliza Hall Institute, which can support these types of projects. We have an FTE from my behalf to establish and maintain this in REDCap. And we also have the ability, I think, in terms of this project structure, to allow the sharing of the REDCap databases or the REDCap structures so that sites can actually start collecting a standardized way their data, and also having a way of analyzing the standardized way so the de-identified aggregate data can be compared across sites. So the aim looking forward is to establish these data standard quality assurance and evaluation project registries, looking for standards of care of treatment of leukemia in the Asia Pacific. You can see the purposes there. You can see what we want to collect in the future, but we're going to be very much guided by the working groups in terms of identifying the projects they want to start with, and also trying to understand those priorities, and we can help support that. So one of the issues that we talked about again last year, and one of the issues about having genomic diagnosis in terms of molecular not necessarily standardized across different countries, is the implementation of the WHO or the ICC coding in 2022. So the WHO ICD-O coding has evolved and very much integrates molecular diagnostics into their standardized collection of data and classification of cancers. So we want to really focus on, I think, in our AML especially, but also ALL registries, in terms of standardizing and understanding the molecular testing available for our patients. We understand that historic data and also ongoing data from sites who do not standardly do next generation sequencing will have to use, for example, the previous WHO classifications. We also recognize that WHO classifications are not complete. For example, they do not recognize FLT3 mutated AML as a separate entity, or IDH mutated AML as a separate entity. But we know biologically and also from a therapeutic point of view, this is one of the most important diagnostic tests we need to know about to actually make our treatments as well. So very simply, what the data we want to collect from a standard data model is a disease classification. We want to code the types of therapy that the patients are receiving, and we want to code some form of outcome, either MRD response or therapeutic response, and potentially survival once we get the appropriate approval through. So this is talking very quickly about where the ICD coding has evolved from back in the 1960s to where it is now, and the schism which occurred with WHO and ICC in 2022, but we are recommending, based on the WHO standard classification and the ability to map previous diagnosis to future diagnosis, the adoption of the WHO standard over the ICC standards. Something that also we've developed locally is the use of automated genomic data extraction from PDF reports, if people are interested in this at different sites. So using, with my collaborators with machine learning engineers, we can actually extract from either OCR or character recognized PDFs or scanned PDFs in a tabular format, any molecular details in a report, and put that into a CSV or computable format. So we can now extract information from PDFs into a CSV file, but in a de-identified way, which which will make computation and development of registries, for example, much easier from a molecular point of view. So discussion points that we can talk about in the session up here, I've just alluded to, and perhaps I'll invite my colleague, Professor Ko, to come up with me to the panel chair.
Thank you, Dr. Ashley. Is Professor Ko, perhaps you want to come up as well? And Dr. Lau Zhetang, he's not here? Oh, okay. Yes, Prof. Go. Microphone for Prof. Go.
Do you want to grab this one?
So actually, I think we leave the CL group out because CL is more complicated. The patients don't die off that early, and then every year, you're gonna start off with AML and ALL first, and each country actually they have their own representatives already. So we got to like see who has already red cap. Like Singapore, we already is on red cap. Whether we can export and then harmonize the fields and then start collecting and make it simple. I suggest you leave out the genomic stuff. It's going to be more complicated, right?
Yeah, I think genomics overall for next generation sequencing will be hard.
Yeah, but let's leave it out. Let's leave it out. So maybe you guys can sort of get the groups working and then start doing it and then how that works. As far as money is concerned, it's going to be a bit tough unless you can talk to our industrial partners here and see. But it would be best if you can do it with minimal cost on your side to actually get it off. I mean, do it FOC first. Then if it starts working a simple way, then we at least. And AML is good because you guys already want to collect data on secondary AML and all the other stuff. So maybe that would be a simple stuff to work with.
No, I agree. I think the project-specific focus is important, and start small. And looking at those specific subgroups of AML, where we don't need to collect everything, but we also know that speaking to the members of the working groups, they already have registry data from their own internal sites that we can start aggregating.
And most people are on the sort of a free rate cap anyway, so it's the same platform, and that can easily be exported to you guys, right?
That's right. And we actually don't need to have the data exported to us or a central repository. Because the red cap standard data fields can be shared, as long as the information is collected in the same way and the analysis is performed the same way, that means that the federated model allows the sites to maintain the data integrity without transferring it. So we actually don't need to enter into any data transfer agreements.
Oh, that's actually very good. Yeah. Okay, so any comments? Is everybody keen? You have representatives for each country already, right?
I think we're going to be focused very much on the working groups in terms of the
priorities. Are you missing any country? Korea, I think we don't have.
Korea and Japan.
Korea and Japan. Japan is Prof. I think he's left, our Korean colleague. So Japan is a big issue, but apparently Prof. He knows the Japanese people, so we'll try to get Japan inside as well, so that Carol, you can get your Japanese. We've been trying to get him for the longest time, so we were working on that. Okay, good, thanks.
Thank you.
We are a bit late because our next session is CML and the speaker is virtual. So
all right, okay. So I think we will wrap up for now.
And
I think is that okay?
Yeah.
So I think if we have any further question, we can approach our Prof. Ko as well as Ashley. And I think the idea of each center maintaining their integrity and no need institution or country agreement is a fantastic idea. I think that will definitely be feasible. Thank you very much. So that's it. We will go for coffee break and we have to be back by 9:50. Am I no?
9:50. Yes.
Okay. All right. Thank you very much.
Yes. Okay, 9:55. Sorry, Eva. Yes. And come back to CML section, please. Thank you.
Very much to all the speakers. Thank you very much.